And today's topic is cognitive behavioral therapy, specifically relapse prevention. I'm presenting with slides that are adopted from ASAP's Dr. Lindsay from previous presentations. So our learning objectives today are to provide a brief overview of CBT, session structure and interventions, to describe classical conditioning as it relates to substance use, and to discuss the role of high-risk situation planning in relapse prevention. So we'll start with an agenda because that's what we do in CBT, a little meta learning here. So we're going to review basic components of CBT, introduce triggers and trigger identification, discuss urge and craving management skills, and address behavioral contingencies and how to use them for relapse prevention. So big picture, the idea here is you're going to get a lot of information generally about what CBTRB is about, and then we're going to go over some interventions that can be sort of excised, pulled out, and used modularly, even if you're not going to do the full CBTRP protocol. So we'll set the stage with the stages of change, which is probably familiar to those of you who attend regularly. This is about that idea of how people move through the process of abstaining from use and maintaining that abstinence and then relapsing. And so the sort of key period for relapse prevention skills is between action and maintenance here. You're trying to catch people where they already have some momentum, they're making some changes about, in terms of their health habits, and you're going to help them make those changes stick, help them get them solidly into maintenance with those relapse prevention skills. So a way to think of this is, patients starting out very acute, you're really just at that harm reduction stage where you're identifying the recovery motive and then trying to help them just use less or use in a safer way. Then CBT is this 2 through 4 steps, just under the general CBT umbrella of identifying triggers, warning signs, and well-being needs. And then the relapse prevention is sort of the crowning touch, the copestone there, where you're putting it all together and it's sort of a cohering whole to make sure that patients get to hold on to all of the gains that they've made and to make it as easy as possible for them to reduce their vulnerability to relapse. So what is CBT? The conceptual underpinnings of CBT are the reciprocal links between thoughts, feelings, and behaviors. It has great evidence for treating substance use disorders. It's definitely the best studied of all of the approaches for substance use disorder psychotherapy treatment. And it works for a variety of substances as well as behavioral addictions. It's very flexible. You can implement it in many settings. It has been developed very much in mind with the sort of primary care or hospital setting, so that if you're not going to do the full treatment, then you can pull out these modular interventions, as we'll discuss today, and use them where and how they can be helpful. If you are doing the sort of gold standard contiguous treatment, it still is very short-term and highly focused, and obviously it works in combination with medication. So the map here of CBT, I'll use an example just to kind of make this stick a little bit more. As you start with an activating trigger, I'll note this is usually conceptualized as being an external trigger, but it can be an internal state like a thought or a mood. But this could be, for example, somebody cutting you off in traffic. And then that leads to a cognition, a thought. So maybe, what is this jerk doing? That can lead to an emotion, feeling resentful, angry, maybe worried for your safety. That can lead to a physiological response, such as increased heart rate, sweating, muscle tension, and in turn, behavior, maybe honking at them, flipping them off, yelling, something like that. And of course, that can lead to further input in that stream, and the cycle can keep going that way. So with CBT, the most general place to intervene is upstream with cognitions. Generally, you can't act directly on emotions or physiology. So cognitions is usually where we start. And by, for example, giving an alternate story of, why is this person cutting you off in traffic? Well, maybe they have a medical emergency. Maybe they're not just a jerk. That's one example of an approach that CBT would use to change the cognition in order to change the downstream behavior, which may be a dangerous one. There are cases where you can start at the endpoint of behavior, such as with behavioral activation, where you get people to engage in healthy behaviors, whether they feel like it or not, and that sort of reverse engineers the healthy experiences, feelings, and thoughts. But generally with CBT, we're most often intervening first with the cognitions. All right, so let's look at the session and the structure of CBT. CBT is very structured. The provider is always taking a very active stance. Typically, it's an hour-long session that's divided into 3 sub-sessions. And the sort of big picture idea of what a CBT provider is doing is trying to balance empathy and acceptance with the responsibility to teach quite a lot of information all at once and make sure that the patient is going to act on it. So there is this constant theme of balancing that structural directiveness with interpersonal responsiveness. So with the first 20 minutes, you're going to set the agenda like we did today. This is what we're going to discuss. You're going to briefly focus on understanding the current context for the patient and how you can relate the material to it, but you're not going to get caught up in this is what the week was like, et cetera. You're really going to want to keep it to what you need to know to make the information salient. What you will focus a lot on are detailed day-by-day descriptions of their substance use or their cravings since the last session. A huge part of CBT is self-monitoring. So they're going to, if they've been practicing as they are expected to, they're going to have taken a lot of notes about what their substance use or cravings and urges for substance use have been like. And you spend a lot of time reviewing and talking over their experience with homework from the previous week, because the most important part of CBT happens outside of session. That's the homework, that's their practice. You want to make sure they understand that and that they feel their time was valued. So you really spend you put a lot of emphasis on that time on homework. For the second part, skills and techniques, you're going to introduce and discuss what that particular topic is, and importantly, integrate it with what is going on in their current sort of their presenting problems, what's most salient to them right then. You do want to make sure that you're doing plenty of comprehension checking, even as you're introducing the skills and techniques. Patients are going to have a very wide variety of, education, literacy level. You want to make sure you're using terminology that fits for them. The great thing about CBT is it's so widely adapted that there are plenty of alternative phrases to use. You don't have to use too much jargon. And then very importantly, you practice the skills in session. You'll role play, you'll go over the worksheets. You're never going to send a patient out to do these assignments without some kind of practice ahead of time. And then for the final 20 minutes, that's the comprehension check. You're making sure that they really understand what they're going to do, that they understand why they're going to do it, very importantly. And you're making sure that they're going to apply it in the way that you expect them to. Collaboratively, you're going to work on, how do we put this into practice during the next week? So this isn't just you handing it down to them. This is talking over how is this going to fit into your life. You're going to troubleshoot what might get in the way of doing homework. And a very important part of CBRP is anticipating high-risk situations. So at the end of every session, you're going to do something called high-risk situation planning, and we'll go over that in more detail later in the presentation. So really in wrapping up, you're making sure that they know what to expect for the week ahead, both for just how they spend their time generally and how they're going to do their homework. Some of the challenges for CBT clinicians are that it can be really, really difficult to stay focused if the patient wants to move to other issues, which they often do. The skills and techniques may feel boring to them in comparison to their concerns in everyday life. And particularly if you're a provider who has previously been trained in a more open-ended or just generally supportive style of therapy, it can be easy to get caught up in that flow of what the patient would prefer to discuss. So it's really important to be able to manage the session flexibly, to be responsive to what's important to the patient so that you're not becoming sort of robotic, but also to make sure that you stay on track so that the patient gets to benefit from everything that the session has to offer. Very often you'll need to problem solve why homework hasn't been done between sessions. You always want to emphasize, you're going to get the best results the more you do the homework, the better fidelity you have with the homework. And sometimes problem solving is logistical. How do we make time for this? How do we make sure that you're able to get to the homework? And sometimes it's about self-confidence or a feeling of hopelessness. So there can be a lot of reasons people aren't doing homework. It's very important to identify it as early as possible and to address it proactively. So let's look at general considerations for CBTRP. In terms of repetition, repetition is used in CBT for all kinds of conditions, just as a learning tool, but it's particularly important with substance use because habits, of course, around substance use are very deeply ingrained. Patients have practiced a lot to get to the point where they have with substance use, so they're going to require a lot of practice for the skills that oppose those habits. Learning new approaches is going to take many, many attempts, and you want to keep their morale up. You don't want them to expect that a new skill or technique is going to work the first time necessarily. Chronic substance use often is going to impair patients' memories, so it's important to just keep revisiting those fundamental concepts such as triggers. And you as a provider do not want to become demoralized if you have to repeat parts of sessions, maybe even whole sessions. That does not necessarily mean that treatment isn't working. That just is often a feature of treatment with this particular population. A really important part that people sometimes overlook with CBT is giving a rationale. So these are going to be unfamiliar and often not particularly easy or appealing skills and techniques that they're learning. You want to make sure you have their buy-in, that they understand how this is going to benefit them, and what kind of a difference it's going to make for them overall in their life. So you constantly want to stress, this is why this skill is important, and this is why practicing it is going to make a difference for you. So monitoring, as I mentioned, is a really important feature of CBT. It's going to allow you to check up on how they're doing, to make sure that they're understanding how to apply the skills and techniques, and that those actually are being translated accurately to their real life. You're making sure that, again, they are indeed completing the tasks, because it's not going to work if they're not doing the homework. And also making sure that they have space to talk over why it is difficult, and what you and the patient can do together to ensure that the homework gets done as it needs to. And sometimes that will require a little bit of accommodation. So in terms of shaping the patient's behavior, you really want to use successive approximation. So this is the sort of more behavioral side. So that means that just as it takes a very long time and a lot of effort for somebody to stop using substances, it takes a lot of time to learn the skills that allow them to do that. So really every little step that they take, any little piece of progress, is something that you want to be a cheerleader for and say, this is great. Remind them that this is forward motion, even if it's not everything they hoped it would be, that it is accumulating towards the greater whole of them ceasing substance use. So any little thing, even if it's just that they show up to session, that's a good thing. You really want to underscore that. If you recognize retrospectively that they did something that was helpful and you didn't capitalize on it, return to it later. This is something for me. It's a really fun part of CBT, is getting to be that cheerleader and getting to really highlight to them. It might not be as big of a change as you expected, but you are making that progress, and that's really important for morale. So in terms of sort of the conceptual underpinnings of CBTRP, the idea is that relapse is caused by an intersection between immediate determinants and then also covert antecedents. Immediate determinants, for example, are high-risk situations, coping skills, outcome expectancies, meaning what do they expect the consequences to be, and then the abstinence violation effect. I'm going to take a moment to define that because it's really important with CBRP. The abstinence violation effect is when a patient does have a lapse, which is very common, and we want to normalize that it does not have to turn into a relapse, but they're going to be tempted to say, well, I messed up, might as well just let the whole thing go. One patient described this to me as letting a slip become a snowball, and I think that's a really helpful way to think of it. If you can discuss that effect with them and predict it ahead of time, then they can catch it in the moment, that thinking, and think, oh, okay, that's the abstinence violation effect. I don't have to let this slip become a snowball. So that's an example of an immediate determinant. And then that happens within the backdrop of these covert antecedents, such as lifestyle factors, and then urges and cravings, those sort of like large mechanical parts of the recovery process. So how CBRP addresses those is through a mixture of specific and global intervention strategies, so that they can intervene at every part of the relapse process. Examples of specific intervention strategies are identifying the high-risk situations for each individual, increasing self-efficacy in managing them, managing lapses, and especially restructuring perceptions of the relapse process, and that's part of that abstinence violation effect. Globally, you're working on that more balanced lifestyles, developing what's called positive addictions. So how are the patients going to spend their time and energy in ways that are going to be healthier for them? And then employing stimulus control and urge management techniques, and developing relapse roadmaps. So we'll look at that at the end of the presentation. So let's look at triggers. This is a really major overarching component in CBRP, and triggers are about understanding both the external, so the environmental, and then also the internal. So things like thoughts and moods, triggers for urges to use, which then become use behaviors. So if you think about triggers and cravings as these sort of links in a chain that end up with using behaviors, the trigger is what starts it off. And often it's not conscious, but there is always some kind of a trigger at the beginning. And a big part of the work here is for the patient to be able to identify what was that trigger. It might be just below sort of the threshold of recognition, but the more practice they have, the better they get at recognizing, aha, in this situation or with this person, or when I have these thoughts, that's when this chain gets started. So it leads to the thought, to the craving, and then if it's not interrupted, the use. And something to keep in mind as we talk about these interventions is that the higher up on the chain you can intervene, the better. Saves the patient a lot of trouble, makes them a lot more likely to be successful. Ideally, they avoid the trigger altogether. That's part of high-risk situation planning. But you can't avoid every trigger, so it's important to have all those skills. So I'm assuming you all are at least somewhat familiar with classical conditioning. That's exemplified by Pavlov's canine experiments, where originally there's the unconditioned stimulus of the food and the unconditioned response of salivation. And then once it's paired with a whistle, the dog responds to the whistle by salivating, which is not originally the response. So how we apply this to substance use, thinking of the initial exposure. So the first time somebody tries substance use, the stimuli that's around them, the environment or what's going on for them, that's going to be neutral. And then the first time the substance use is going to be unconditioned and lead to that unconditioned response. But then in subsequent turns, and one of the things that's so difficult with substance use is that substances are so powerfully reinforcing. They're very potent and they're very immediate, that it really can happen the first time, that anything that gets associated with the substance use then becomes part of that conditioned stimulus and leads to a conditioned response. So can also lead to urges and cravings. So I think as a provider, it's really, really helpful to remember that when we're struggling with how much our patients are struggling and how long it takes and how much effort it takes to recover from substance use, to remember that the world really becomes a landmine for people who have been using substances for a while. Things that seem totally innocuous or innocent have become caught up in this kind of associative web. So, people are walking around and just kind of getting hit out of nowhere with triggers that nobody else might recognize as triggers because they've been uniquely conditioned for that person as a stimulus. So how do we get at those triggers? The functional analysis is a really important intervention for CBT, as well as a lot of other approaches for substance use. And that's where we're looking at what's called substance set and setting, which is also just people, places, and things, so that we can identify triggers and high-risk situations. You're also going to look at long and short-term positive and negative consequences of substance use with a functional analysis and develop positive reinforcements, aka behavioral contingencies and meaningful alternatives to use when the trigger is present. So a functional analysis is actually fairly straightforward in some senses. It's going to evolve as you're using it with patients. So initially you spend a lot of time on the external and the internal triggers. And then as they have more practice with that, you get to look more closely at the behavior, at the short-term positive consequences and the long-term negative consequences. And something that's really interesting about using the functional analysis in a context where the support system is involved is that you'll notice very quickly that the short-term positive consequences are very obvious to the patient themselves. They're very clear about how it's helpful to them most of the time. But that's not clear to the family members, and the reverse is true for long-term negative consequences. It tends to be very, very clear to a patient's loved ones how this is making their life more difficult or unsafe in the long run, and much more opaque to a patient originally. But after enough practice, that tends to become more clear. So let's move to behavioral contingencies. So what do we do once we know more about the triggers? So how do we understand those connections between the urges to use and the use behavior so that we can disrupt them effectively? In terms of positive and negative consequences, this terminology is a little bit different with behavioral health than it is just colloquially. So in terms of consequences, it's just sort of like an outcome, what is going to happen because of a precipitant. So both types of consequences can change behavior, but very importantly, rewards, which are positive consequences, increase desired behaviors, whereas punishments, negative consequences, are just going to decrease undesired behaviors. And in a sense, most of the time, they're just kind of covering up undesired behaviors rather than actually correcting them or providing meaningful alternatives. So that's why we really prefer a positive consequence approach, because that way we can build new skills that stick, rather than just, often the behavior will reappear if the punishments disappear. Also, the effects from awards are just more pronounced and long-lasting, and in terms of the therapeutic relationship, obviously contributes a lot more to rapport when you can use positive consequences or build those in than relying on negative consequences. So in terms of applying contingencies, we've talked in this echo a lot about historically about contingency management, and that's sort of the classic model. Different targets that you can use behaviorally are attendance or abstinence or reduction in use. And then examples of reinforcing consequences or rewards are everything from money, privileges, sobriety chips to positive reinforcement just verbally from providers and family. And something to remember is that you don't want to assume that you know what's most reinforcing for the patient because they often will surprise you. You really want to feel out and get that feedback from them. What really helps you to stick to the plan, what makes you feel good, when you're seeing that progress and getting rewarded for it. So alternatives to use, that's part of that positive consequence framework of, how can a patient learn to feel good in other ways? So what we're trying to do is help a patient identify what are meaningful alternatives to use, not in terms of potency, that's just not going to happen, but in terms of sort of the genre. So if they are using substances to relax, what are other things that they can do to relax? If they're using it to improve their mood, what are other things they can do to improve their mood? You don't want to lose a patient's trust by insinuating that taking a bubble bath is going to be just as relaxing as injecting heroin. Obviously, that's disingenuous. This is about a paradigmatic shift for them, changing the way they look at how they manage their internal and external circumstances so that they can be safer and be happier in the long run rather than be relying on the immediate gratification of the old health behavior. And you do want to make sure that you're generating as many alternative activities as possible because you want them to have lots of options to pivot to when the situation comes up. In terms of urge management, this is about understanding how to identify and modify those urges to use before they turn into the actual use behavior. So as I said, monitoring is a really important part of CBT. The daily record of urges is an important part of that. This is sort of the most basic format. They're going to just include, what was going on, what was the intensity of the cravings, what were their coping behaviors. At the beginning of treatment, you're going to notice that the intensity is very high and the coping behaviors, there's often nothing at all or very little there. Something that's really rewarding for patients to see is that as they stick to this, the intensity of the cravings does go down and the coping behavior repertoire expands pretty significantly. So when you see those empty columns over on coping behaviors, that's the sign that you really want to start working on urge management and other coping behaviors. This is a slightly more complex version of the same idea. This is just all about helping the patient map out, what are the situations that make me vulnerable, what sets me up to use, what can I do to interrupt? And again, monitoring this has the secondary benefit of allowing them to see their progress when they stick with the homework. So urge surfing, I wanted to include a basic example of urge management. And this is an abbreviated script. I won't go through all of it for time purposes, but the idea with teaching urge surfing is that the sort of intuitive response for a lot of people when an urge comes up is to try to fight it, is to try to sort of bat it away and say, no, I'm not going to do that. And what we know about rebound effect there is that that's actually going to make your brain pay more attention to it, and it's kind of going to make it actually harder. Much like if you're going to try to stand your ground with a big wave, it's almost inevitably going to knock you over. Whereas if you decide to just surf along the top, it's a more peaceful ride. So that's the concept with urge surfing. You're noticing the urges, you're letting them unfold instead of trying to fight them or ignore them. And the really important part here is to remind patients that urges always pass with time. They usually peak within 20 to 30 minutes. So if the only thing the patient does is to just delay use or distract themselves, have their support person take them out of the environment, do something that's just that's antithetical to substance use, then they're going to last it. But it's really important that they realize that urge will pass because it doesn't feel like it will in the moment. And every time they do that, they're strengthening that muscle. So every time they surf the wave, they become a better surfer and the wave gets smaller. The precursor to that, of course, is learning to identify and label the urges. So you really only want to move to this intervention once you've done a little bit of that daily record monitoring so that you have a sense of the patterns and you have something to kind of stick this to. So high-risk situation planning is something you're going to do in every single session. That's how you're going to end every session if you're doing gold standard CBTRP. And that's about identifying the context that increases risks. It's not about a single variable like seeing foil or driving past a drug dealer's house. It's about a sort of constellation of factors that's going to make the patient much more vulnerable to relapse, and planning for it. So the idea there is, just as we plan for a fire escape route, it doesn't mean that we're saying a fire is going to happen. It's that we don't want to have to think in the moment when we're stressed out and there are all these distractions about what route we're going to take. Same thing. If they end up in a high-risk situation, we don't want them to have to improvise. We want them to know ahead of time how they're going to manage it. This sounds really basic, but when patients can stick with it, it really is like a game changer. And that's just really reinforcing that the situations that have been caught in that associative net of substance use, those are high-risk situations. So anything that is connected mentally or emotionally to substance use is a high-risk situation. Whereas people, situations, and places that have never been associated with substance use are low-risk situations. Again, it sounds so basic, but when we can help patients to reorient so that they're decreasing their time in high-risk situations and increasing their time in low-risk situations, and of course, having a plan if they do have to be in a high-risk situation, this can be really one of the most dramatic contributors to seeing substance use just absolutely drop off. Because if they can do that, it makes the rest of it so much easier for them. So this is the basic format for what you would be planning out at the end of every session. You're going to say, what are the situations this week that are high risk for you? Ideally, you want to see, is there a way to just get out of that situation? Because like we talked about, that's the top of the chain. That's just, getting them out before the triggers even happen. But you also, you can't avoid every trigger, and you don't want the world to become so small that they avoid everything. So if they're in that situation, what are they going to do? Are they going to call a support person? Are they going to use their feet to walk away? If so, at what point? What's the sign? You really want to make sure that they've gone through it very thoroughly, and then that they carry this with them. It could be that they take a picture of it. It could be they write it down and keep it in their wallet, but you want to make sure it's with them so that they're not having to think it through when the moment hits. So in terms of planning, again, it really sounds so basic, but for this population, very often these patients haven't learned the skill of planning out their day. And it's that sort of idle hands issue where when there isn't a structured plan in place, it's just very easy for them to fall back into old habits of spending their time and resources. So you really want to map out in tedious detail what each day is going to hold for them. It's going to be boring for them. It's going to be boring for you, but it's important to emphasize this really is actually the most concrete way for them to ensure their sobriety, for them to protect the changes that they've made. If they really can stay out of high-risk situations and maximize their time in low-risk, non-triggering situations, they're just dramatically much more likely to avoid triggers and thereby avoid using. So I included, to wrap up, just a couple quick intervention examples that go along with this. So the seemingly irrelevant decisions framework, this is that idea that it's not always a glaring red flag before people get into a high-risk situation. A lot of times it's what seems like little innocent decisions, but once a patient learns how to sort of identify some of these precursors, then they realize, hey, I'm an active arbiter of my fate here. I don't just kind of fall into these situations where the substance is present, or where I'm tempted to use. I do have some choice over it, but I need to be alert to what those signals are. So some of those components are thinking through the ramifications of what seem like even small decisions of where they go or who they spend time with, recognizing risky thoughts like, well, I have to attend this social event, or, I can handle being around the substance a little bit, or doesn't matter if I try just a little bit. And then also that sort of self-empowerment piece of putting their own needs and sobriety first, not accommodating other people, in order to be able to interrupt that chain of events really early. So this is kind of a choose your own adventure model, helping them to recognize the pathways that their choices determine. Identifying warning signs. So that's the idea that they've built new healthy habits, and when they recognize reversion to old habits, that's often a precursor to a relapse. A really common one that I see is people maintaining a great exercise routine as they stop using substances. And then once they start saying, I don't have to go to the gym, or maybe I can skip this run, that often is a preamble to a relapse. And lastly, importantly, this has to do with the abstinence violation effect. You want to predict that slips and relapses will happen and think through how to handle them. The classic here is 3 ways one can think of a slip as a mistake from which you learn something and grow, or a hopeless disaster. The third way often does lead to relapse, so you really want to predict that thinking might come up and tell them you do not need to go down that path. you can think of it as a growth opportunity. And in terms of what to do instead, you emphasize don't panic. You interrupt the flow of events by stop looking and listening instead of going into automatic mode. You remember what they've already learned about the abstinence violation effect, return to their motivation for ceasing use, renewing their commitment, and then decide on a course of action. So the main thing here is you're interrupting the automaticity of substance use and saying, you get to decide what happens from here.